Okay, this is it. Last one. Yay! We're going to talk about the central nervous system tracts. And having now lulled you into a false sense of complacency with three relatively simple, straightforward, here's how you test this, here's how you test that parts, we're going to dive deep now and talk about what those tests actually mean and what it is that you're testing. So this is, I've been saying through a lot of this lecture, it's all just very basic and straightforward and just do this and look for that. Now we're going to talk about why you're doing that. So you can download the PowerPoints from Paramedicine.com, go get them. This is the map that I'm going to be giving to you. I'm going to build up this map sequentially over the next 9 slides or whatever it is. This is what we're going to be learning, okay? So let's back up and talk about tracts. Now, I used to teach this and talk about tracts, and people at the end of the lecture would say, but what exactly is a tract? So a tract is just a bundle of nerves that are traveling together. So when you have a bunch of nerves going together, we say instead of a bunch of nerves or a bundle of nerves, we just use the fancy word tract, and we say that it's a tract. Okay, so the sensory tracts take sensory data from our sensory organs, usually our skin, and send them up into the spine and then up into the brain. So we say that the sensory tracts are ascending tracts. They go up to our brain. And the motor tracts, we create the signal in our motor cortex for what we want to move, and then we send that signal down our spine and then out through our body. So we call them descending tracts. So we got the sensory ascending and the motor descending, okay? Now the sensory tracts that go up to the brain go up through the front, the anterior portion of the spine, and the lateral portion of the spine, spinal cord, the spine's the bones. So they go up through the interior and lateral portion of the spinal cord, and they go up to the thalamus. So we call it, quite reasonably, the anterolateral spinothalamic tract, which sounds like a big wonky, $10 medical word, but it's really just perfectly descriptive. Anterolateral spinothalamic tract. And that's what it is. That's our sensory tract. So when we're drawing this complex map that I introduced at the beginning, well, this is really easy. The sensory tracts, which are ascending, go through what part of the spine? Spinal cord, front and side, up to the thalamus. So we call them the anterolateral spinothalamic tract. And then, that's all we need to talk about for those. Now we're going to talk about the motor tracts. So the sensory tracts are easy. There's only one, and it's the anterolateral spinothalamic tract. So let's talk about the motor tracts. Here's how we move. We usually create a stimulus in there's that sulcus through our brain in the middle, you can see it. And in the front of that is the motor cortex. And again, I talk about this a lot more in the hemiplegia lecture that's on YouTube. So if you want to, go look for that. But we create an impulse. I want to scratch my nose. So that happens up here, and that travels down into our spinal cord or our brain stem and exits from the spinal cord or brain stem through a ganglia. So we go from one nerve, get off the road, go onto the next road or portage across the lake, whatever you want to do, and then go across down the next nerve until we hit the muscle. And when we hit the muscle, there's the neuromuscular junction, nerves and muscles. We spit a little bit of chemical across there, and that stimulates the muscle to contract. So there are various motor centers in the brain. They travel through the upper motor neurons, the first ones marked in red there, to ganglia, which are junctions where one neuron meets the other, and then they travel from that ganglia down through the lower motor neurons down to the muscles. And then those lower motor neurons attach onto the muscles at the neuromuscular junction. Again, really obvious, right? And this is what the neuromuscular junction looks like. I'm not going to go into the details of transmission, but basically we have the nerve coming down. It's that big upside down mushroom sort of thing. And the vesicles of acetylcholine, the little balls of acetylcholine, come out. They go across that gap and they go on to acetylcholine receptors. And the acetylcholine receptors are stimulated, and that causes the muscle to begin to contract. And the acetylcholine would cause the muscle to continue to contract forever if we didn't do something to get rid of it. So the way our body gets rid of it is with another chemical called acetylcholine esterase. And an esterase is something that breaks things down. So the acetylcholine esterase breaks down the acetylcholine into ingredients, and those ingredients go back up into the terminal button of the axon and get formed back into acetylcholine, and the whole thing resets. This process is actually very important in emergency medicine because when we want to paralyze somebody's muscles, then we give them drugs that interfere with this transmission across the synaptic cleft. And those are called neuromuscular blockers. So succinylcholine, pancuronium, vecuronium, rocuronium, there's a bunch of them. They act in this neuromuscular junction. So if you're going to higher levels of paramedicine where you're using neuromuscular blockers, this is what we're doing in the neuromuscular junction. Interestingly, even if you're not a paramedic, you actually do this yourself. We block our own neuromuscular junctions when we go to sleep. So as we're falling asleep, our body will shut down that connection so that when you're, running from wild things in your dreams, you're not pelting the person you're sleeping beside. Your body stays still because you have been chemically paralyzed at the neuromuscular junction intrinsically. Some people have a very frightening condition called sleep paralysis. And what happens in sleep paralysis is that you wake up before that neuromuscular blockade stops. So you wake up and you're paralyzed. You can still breathe, but your voluntary muscles won't work. So you lie there trapped in your own body. That's called sleep paralysis. My youngest daughter has sleep paralysis, or did for a while, and it's really, really frightening. So it's an important part of our body, just for something for you to be aware of. And interestingly, when we do go to sleep and we're depolarizing that neuromuscular junction and then stopping it, that's when we get those nocturnal myoclonic jerks of going to sleep, because we're depolarizing our neuromuscular junction so it can't polarize anymore, and then boom, we're paralyzed. We're properly asleep. Okay, interesting. So let's talk about those motor tracts. The motor tracts are divided into two different tracts, and those two different tracts take two different paths down the brain. Down the spinal cord, and out to the body. And we call these tracts the pyramidal tracts and the extrapyramidal tracts. So this is the next thing in our map here. We've got pyramidal tracts and we've got extrapyramidal tracts, and we're going to talk about what those different tracts are. But first, what do pyramids have to do with motor neurons? Like, where did that even come from? I remember talking about learning about extrapyramidal syndromes, and I just thought, like, Egypt? Pyramids? Why on earth would we call them that? So here's the answer. If we go down into our brainstem, in the medulla oblongata, there are two sort of column-ish looking things. You can see them down there in the bottom of the screen. And I don't know why they're called pyramids, because they don't look like pyramids to me. They look more like hot dogs. But they're called the pyramids. Everybody calls them that, so just, go with it. And some of the motor tracts go through those pyramids, and those are the pyramidal tracts, and some of them take a detour around the pyramids and don't go through the pyramids, and those are called the extrapyramidal tracts. That's where the name comes from. They don't look like pyramids, that's what we call them. Some of the motor pathways go through the pyramids, some of them go outside. And the ones that go through have very distinct motor activities, and the ones that go outside also have very distinct motor activities. So you can take a look at what someone's doing, physically, how they're moving, and say, oh, those are the pyramidal pathways that they're using. And other ones, like if I do this, that's a pyramidal pathway because it's a large voluntary muscle that's relatively specific. So that's a pyramidal pathway. If you take a look at my posture, which I just realized is kind of bad, I should sit up straight while I'm doing this, that's extrapyramidal. So let's talk about those. First, we'll talk about the pyramidal tracts. And as I said, there are pyramidal and extrapyramidal. Now we're going to do an additional subdivision. So there's pyramidal and there's extrapyramidal, but the pyramidal actually has two tracts as well. So both of these start up in the cerebral cortex And some go down and then come out through the facial nerves and modulate facial movement. The other ones go down to our body. So if I'm doing this, that's a pyramidal tract action. If I'm doing this, that's a pyramidal tract action. The one that goes from our cortex to our face is called the pyramidal tract that goes from the cortex to the face is called the cortical bulbar tract. Now, it makes sense that we would call it the cortical tract because that's where it starts. So the word starts with cortical. But why bulbar? I don't know. But the way I remember it is if you remember Rudolph the Red-Nosed Reindeer, he had a bulb on the end of his nose. So do clowns. So the end of your nose is kind of a bulb. So when we go from the cortex down to our face, that's the cortical bulbar tract. And that's how I remember it. So sometimes I'll ask on an exam, your patient is smiling. Explain the tract that those impulses are going through for the smile to occur. And I'm expecting people to say it's the cortical bulbar pyramidal tract. Easy. Other impulses don't go out to the face. They go from the cortex down to the spine to our body. So when I go this, that's a cortical bulbar pyramidal tract. When I do this, that's a cortical spinal pyramidal tract. Okay? So those are those motor tracts, the pyramidal motor tracts. So let's fill them in. Our map's almost done here. We got the pyramidal tracts, we got cortical bulbar, and we've got cortical spinal. The cortical bulbar goes to the face, cortical spinal goes to the rest of the voluntary muscles in the body. Good. So obviously what's left now is the extrapyramidal tracts. So let's take a look at those. There are actually a few. I think there's like 5. And they have neurons that start in the lower part of the brain. So these are less voluntary in a way. These are more of our automatic movements. So if you want to think about the pyramidal tracts tend to be our intentional movements, and the extrapyramidal tracts tend to be our non-intentional kind of spontaneous movements. So, quick reflex jerk type of things, or posture, or, well, we'll get into it. But those tracts control things like our involuntary motor reflexes, walking about, keeping balanced as we walk around, because you don't necessarily think I'm 3 degrees to the left. I have to correct with my, abdominal cortex, blah, blah, blah. We stand up and we just stand up. We don't think about it. It's automatic. So complicated movements, intricate movements, especially with our hands, playing piano, playing guitar. Another common exam question. You notice somebody's playing piano. Explain what tract they are utilizing to control their hand movements on the piano. And we would be looking for the extrapyramidal tracts. That's what we want to see. And control of our posture. So when your teacher tells you to sit up straight, they could be saying, mind your extrapyramidal tracts because your posture is slouching. Okay? So, how do those extrapyramidal tracts work? Well, they work by neurons firing, and neurons fire using chemicals. And the dopamine and acetylcholine in our brains maintain a balance to make sure that we're not firing those muscles too much, and we're not firing them so we're rigid and hyperflexed, and we're not flexing them, or we're not stimulating them too little, which means we'd be hypotonic. We'd basically just be collapsed on the ground because we wouldn't be able to maintain our posture. There are some antipsychotic medications that we give to patients that will cause an imbalance between the dopamine and the acetylcholine. Droperidol is a drug that paramedics will often give for violent, aggressive patients. It's a chemical sedative or a chemical restraint device. And sometimes this will interfere so much with the balance between dopamine and acetylcholine that they start having weird movement symptoms, which we'll talk about in a minute. But if you're giving these drugs, you have to be aware that this is a potential side effect, and you have to be ready to get on top of that. So we call those weird movements extrapyramidal side effects, or EPS. You'll often see it abbreviated as. And there are 4 distinct weird motions that we will see when we give patients these antipsychotics and throw off the balance between dopamine and acetylcholine. Usually there's one of them that comes first. So this is the one, they happen in a bit of a sequential order. So this is the weird posturing, the weird motor movements that we teach paramedics to look for when they're administering antipsychotics. So some of these, of course, will happen over long term. Like a psychiatrist might prescribe antipsychotics, and then, a few months later, they start getting into tardive dyskinesia, which is a terrible condition, which is often permanent. So that's a bit tragic. You might go to somebody who has tardives, and it's because they were given medications. So the one we normally see is acute dystonia, and this is acute dystonia. So you'll see facial grimacing, the eyes will roll up, they'll often be a torticollis, they'll often extend their tongue, and they'll go into this epistotonus sort of posture where they're arching their head back, almost like decerebrate posturing in a way. And if you ever see a patient doing this, then that is a classic acute dystonic extrapyramidal symptom, or sometimes people call it extrapyramidal syndrome. So we look for acute dystonia, and we can actually treat that. We can treat that with anticholinergic agents. There's a good video on YouTube, hopefully it stays up there, of this gentleman who very graciously allowed himself to be filmed and posted to YouTube, coming in with an acute dystonic reaction. He's conscious, he can still speak, although he can't articulate very well. But he's right there. He's just having problems with his motor muscle control. So take a look at that. It's a good one. It's pretty classic. And you'll get an idea of what acute dystonia looks like. So what do we do? Sometimes these are called acute dystonic reactions or extrapyramidal syndromes, or there's a bunch of different names for them. Generally, we give anticholinergics, so benztropine, plus or minus antihistamines, plus or minus benzos, plus or minus beta blockers in various different ways. So take a look at your clinical practice guidelines and see what your instructions are and which drugs you carry. Normally, you'll find that because extrapyramidal syndrome isn't immediately life-threatening, the first tier of paramedics, so like EMTB in the States, or primary care paramedic in Canada, or advanced care paramedic in Australia, don't give these drugs. It's the NREMTPs or the advanced care paramedics or critical care paramedics in Canada, and the intensive or critical care or the MICAs in Australia that will give. So second level. Right? Those are usually the paramedics that we call in when there are extrapyramidal symptoms because they carry the drugs to help reverse the extrapyramidal syndromes. And also, you can sometimes get laryngospasm with extrapyramidal symptoms. And if that happens, OPAs, NPAs, LMAs, they're not going to work. What you really need to do is open up their mouths and squirt some lidocaine onto their vocal cords to stop them from depolarizing so they become flaccid, and then we intubate them. And that's obviously an advanced level of practice. So that's where the second tier of paramedics will start to intervene. So if you're at the first tier of paramedicine and you notice somebody with extrapyramidal symptoms and they seem to be okay and you're not far from the hospital, you can probably just transport them. If there's any indication of airway compromise or impending airway compromise, then get the next level of paramedics there as soon as you can, because the last thing you want for them is to just close off their glottis and die on you, when it's actually fairly easy to reverse with just a little bit of xylocaine or lidocaine. Okay, so let's fill that in. Extrapyramidal tracts. There's a bunch of different tracts. There's 5, and they control things like the involuntary muscle movements and the very fine sort of specifically with your hands, muscle movements. Playing a musical instrument, all extrapyramidal. That's what I want you to know. You should know this chart. You should be able to reproduce this chart. So sketch it down. I don't know if you've ever heard of my origami method of studying, but take a piece of paper, fold it in half again. Now you got 4 panels on one side, 4 panels on the other side. So what you do is you draw this on one of those panels and then check if you did it right. Flip it over, and again, from memory, draw it on another panel. Check if you got it right. Keep doing that. Do it 8 times and make sure you've got it right. And if you don't have it right and easy, if you can't draw it from the bottom up on the last panel, then you just bought yourself another piece of paper and draw it again 8 times so that you get this thing down. I want you to know it. Why do I want you to know it? You know, medicine is endlessly deep. You could do your PhD on one aspect of these things. So why do I want to go this far down the hole? Why is it important that I think that you know this? I'll tell you why. Here's why. So when we are assessing our patient, doing our tests that I've been teaching you, the simple tests, this is the mental schemata that we use for what we're actually testing. So when we see somebody doing decerebrate posturing to pain, D means bad and cerebret means the brain. So we literally see bad brain posturing. And when somebody is doing decerebrate posturing and extending like that, it means their brain is not good. And the lesion, the problem, is happening up in the brain. If we have dermatome tests and somebody can't feel us touching them, or when we do touch them, it feels weird, then that's our anterolateral spinothalamic tract. That's our sensory tract. So when there's problems with the dermatomes, we're in the sensory tract. Again, you can see all the exam questions coming out of this, right? It's so easy to test whether you know this or not. So if we're testing the myotomes and we notice that somebody's having difficulty in general moving a part of their body, we know that they're having a problem in their myotomes, so that's the motor tracts that have a difficulty. And we can get more specific. So if we see facial weakness, for example, if we see, you know, ptosis on the face, and we see, you know, unilateral paralysis on the face, then we know that that is a problem in the pyramidal, cortical, bulbar tracts. So you know what part of the wiring you're going through. The Babinski sign is the cortical spinal tract dysfunction, and decorticate posturing, which literally means D, bad, and corticate, the cortical positioning, posturing, also means that we have corticospinal problems. So if I ask you, well, what does Babinski sign mean? Or what does decorticate mean? Then you have an understanding. And here's a question. People will sometimes ask, which is worse, decerebrate or decorticate posturing? And when you're first learning about this, you think, well, you know, decorticate is bad, but at least you're still protecting yourself. Decerebrate is really bad because you're not protecting yourself. But the more accurate physiological answer is that decorticate is bad, but it's only the corticospinal tract in the pyramidal tracts. When you're doing decerebrate, that means it's your entire brain. So that's worse. I'd rather, you know, if I'm going to get injured, I want to get injured as far down this flowchart as possible. So the last thing I want is decerebrate posturing, because that indicates that my entire brain is in trouble. And when you see decerebrate posturing in a trauma patient or a traumatic brain injury, you think, wow, that's really bad. That's their whole brain. So the involuntary motor reflexes, that's our ekathesia and tardive dyskinesia. The coming down to the complicated movements, especially in our hands, you'll see Parkinsonian symptoms, which often has the pill rolling. That's why, because it's the motor fine control of the hands. And problems here in control of our posture suggest the extrapyramidal tracts. And what drug do paramedics give, or what drugs do paramedics give, which can cause this? Haloperidol, droperidol, drugs like that. And that's where we get the control of our posture going wrong. Live it, learn it, love it. If you know this, then you really understand at a deep level, deep enough for paramedics, what's going on in the various wiring systems in our body. So that's it. Now, this is the summary slide I should have presented, not the last time, but here. So we've gone over all of this information, some of it very simple, just test this, test that, test this, test that. But now at the end here, we've talked about the central nervous system tracts, and we've talked about why you test it and what abnormalities mean. And you can start to localize lesions in the central nervous system based on the patient's presentation. You're practicing paramedicine. Good for you. So, remember when we first came in and started this lecture, we said, how's your patient? This has been the roadmap of the lecture. So what I would suggest you do is the very first thing is learn to say this. Even if you don't know what it means, just learn to vomit it out verbatim so that you have the pathway of what it is that you can unpack in the rest of this lecture. We've talked through all of this and we've given you a detailed anatomical explanation of what it is you're testing and what problems indicate. So you're really well prepared now to do a neurological exam. If you got any questions, put them into the comments. I was going to do some videos demonstrating how to do this stuff, but I realized as I was doing the lectures that I think it's pretty clear, stroke here, stroke there, touch this, touch that, clench, open. I think you should be able to get it. If you're struggling with it and you really don't understand what I'm talking about, and there are a lot of people saying, I don't get it, I just don't get it, then I'll do some videos if you want. But honestly, I think you should be able to do this. And again, you could learn to do this whole thing in a good 1 or 2 hour lab. You should be able to practice it and get it down. You can get the mechanical process down in an hour easy. And then with a bit of studying, you'll be able to understand exactly what it is that you're doing and what the various problems mean. So, hope you enjoyed it. I enjoyed doing it. I enjoyed producing this lecture. It was a lot of good consolidated learning for me. So let me know if you have any questions and happy to answer them. And thanks for watching.